next speaker is Kinika Young. She is the Senior Director of Health Policy and Advocacy at the Tennessee Justice Center. Kinika is a lawyer and health policy advocate who frequently speaks on issues concerning access to healthcare, focusing on the role of public benefit programs to help people who lack adequate resources to meet their needs. She graduated from Florida A&M University with a degree in political science and earned her Juris Doctor degree from Tulane University Law School. In her role at the Tennessee Justice Center, she leads efforts to build a movement across the state to protect and strengthen safety nets for children, families, seniors, people with disabilities, and move towards the equitable allocation of resources to all Tennesseans. Kinika was also recently appointed by Mayor Cooper to the Healthy Nashville Leadership Council. Thank you for sharing your work with us today, Kinika.
Thank you so much for the introduction, and thanks for having me. Good morning, everybody, on this crisp fall morning. I hope you can get out after this and enjoy the good weather we're having. So for my presentation today, I want to start with the premise that the analysis of health disparities must be examined through the lens of racism. Racism exists. I know more and more these days there are disputes about what's true and what's fake news, but I'm stating this as a matter of fact and not opinion. Racism shows up in various ways and in various systems. And so with health disparities, they should be considered within the context of health inequities and the practices and policies that embody and reflect racism. One of the primary health inequities that causes poor health outcomes for Black people is the denial of access to healthcare because of political choices made by state leaders. And another factor is poor quality of care that is often linked to providers' implicit racial bias. The pandemic that we're living through has opened a lot of people's eyes to how racism shows up in our society. Some people have called the novel coronavirus a great equalizer, and that everyone is affected, but not everyone is affected to the same degree. Most people have seen news reports about disproportionately high rates of cases, hospitalizations, and deaths among Black people. And I know Monique Anthony is going to talk about health disparities and the impact of COVID-19, so I won't dwell on the pandemic, but it provides important context for this discussion. And what I want to talk about are the underlying reasons for these disparities and what can be done about them, specifically through expanding health coverage. So on this slide, I want to use this to do a little bit of level setting and consider the differences between health disparities and health inequities. So on the left, you see health disparities, and that I define as different groups having different health outcomes. So there are higher rates of infant mortality and maternal mortality, specifically for Black women and Black infants. Black women are 3 times more likely to die from pregnancy-related complications and twice as likely to lose an infant within the first year of life than white women. Also, you see higher rates of chronic conditions and diseases among the Black community and other communities of color. For example, obesity and asthma. And it's notable because obesity is one of the really important predictors of severe coronavirus illness. And so when you have higher rates of obesity, you see more serious illness from that one disease in particular. And it's really alarming because the US has the highest obesity rate, or one of the highest obesity rates in the world. And another is asthma. And considering this also raises environmental factors. It's more likely that people of color will live in neighborhoods that have higher rates of pollution due to segregation and other factors such as environmental racism, where it's more likely to have a pollution producing element such as a factory or other stressors, climate stressors located in low income communities. And so this is another way that people of color are disproportionately impacted by policy decisions. And then lower life expectancy. This is a really significant health disparity in that Black people have a lower life expectancy on average than white people, and there are lots of factors that play into that. So all of these are just examples of health disparities, the idea that certain people have different health outcomes compared to other races. Then on the right side, we see health inequities. This is defined as different groups having different access to resources. And Jacqueline talked a lot about social determinants of health, so you can recognize this list. And the point that I really want to iterate is that all of these resources are systems that are impacted by racism. Our education system, we still have segregated schools in our country. Housing, we still live in largely segregated neighborhoods in a lot of places. Food, we know that in low-income neighborhoods, access to grocery stores with fresh fruits and meats is an issue. Transportation, our city, if you're located in Nashville, we've seen our share of struggles with issues related to mass transit and the push against providing public transit that is more accessible and convenient and affordable for people. That is an issue that disproportionately impacts people of color who rely on public transportation to a greater extent. Employment. There are countless examples of discrimination in employment dating back to the beginnings of this country in terms of people not being permitted to work in certain fields and being steered towards more low wage paying jobs. And then healthcare. That's where we want to spend a lot of our focus today in terms of how racism shows up in our healthcare system in terms of access for people of color in our country. And I would like to also just mention here that poverty alone is not the issue here. There's more to this problem of having inequitable distribution of resources. And there's a body of research that talks about something called the weathering hypothesis. This was first introduced in 1992 by Arlene Geronimus, and it states that the health of African-American women in particular may begin to deteriorate in early adulthood as a physical consequence of cumulative socioeconomic disadvantage. The weathering hypothesis has been cited extensively, and further studies have revealed that there's evidence that poverty alone is not responsible for the racial inequities in health that exist between Black and white Americans. And so these stressors, including racial discrimination and its attendant consequences, can cause a type of accelerated aging that then shows up in the health disparities that we note for different races. If we could go to the next slide. So the flip side of health disparities is health equity. And Jacqueline did a great job of explaining the difference between equality and equity. So I won't linger on this topic, but to answer the question of what's needed to be healthy, we must consider social determinants of health. And we know that equality is not the answer for the reasons that Jacqueline has already explained. So we need to move towards equity and really understanding the social determinants that need to be addressed in order to advance equity. Next slide, please. So again, with social determinants of health, we're talking about things like education, healthcare, environment or neighborhood, economic stability, and social and community context. They all come together to influence our health. And this quote from Howard Koh, which is health is much more than an interaction in a provider's office. Health starts where people live, labor, learn, play, and pray. This was made following a speech by Dr. Jack Geiger, who is a co-founder of the Community Health Center movement in our country. Dr. Geiger was first exposed to the community health center model while visiting South Africa, and then he brought that model to Mississippi, where he worked in the 1960s in the second poorest county in the country. And that's where he and his colleagues worked largely on living conditions and on addressing malnourishment to provide community health and improve health outcomes for the community. So social determinants of health are inextricably linked to racism. We see a lasting impact of policies such as government redlining that were in place in the 1930s, under which Black communities were excluded from mortgage lending programs and business investment. And that means that even to this day, many Black residents live in segregated neighborhoods that lack job opportunities. They lack adequately funded schools, they lack stable housing, they lack grocery stores with healthy food and other resources. And that's why your zip code often predicts your health outcomes. So considering social determinants of health forces us to re-examine the role of personal responsibility or personal behavior in health outcomes. People can only choose from the choices that are available to them. And so addressing these issues requires looking at systems and how policies actually impact people's lives. Next slide. So as a result of our failure to invest in addressing social needs, we've seen health inequities increase at a huge cost. Health inequities actually, it's been estimated to cost our healthcare system $93 billion. The economic costs of health inequities are around 135 billion. And by 2050, fixing the problem would actually add $230 billion annually to the US economy. So for people who care more about money than people, this is something that really should stand out to them and really understand that we're losing out by not addressing these issues. We also need to consider the changing demographics of our country. In 2012, the majority of births were of babies of color. Today, the majority of kids under age 10 are of color. In 2020, the majority of people 18 and under are of color. And by 2045, it's projected that our country will be majority of people of color. And so it's imperative that we achieve health equity to avoid ongoing and repeated public health crises. Next slide, please. So let's take a step back to discuss how we got to this place of health inequities in our US healthcare system. So COVID-19 isn't the first disease to have a disproportionate impact on Black Americans. There was a smallpox epidemic in the South and around the time of the Civil War. And the Freedmen's Bureau was actually, or the medical division of the Freedmen's Bureau was our country's first federal healthcare program. It was established to provide healthcare and other resources to the Black Americans at that time, but also to poor white people in the South. But this Freedmen's Bureau was woefully understaffed and under-resourced. And so there was no real opportunity for poor people, and specifically people of color, Black people, to get the health care and resources that they needed in terms of sanitary living conditions, access to food, to achieve nutrition and what have you. And so health was an issue just starting right out of the gate for Black people in this country. Fast forward a bit to the 1930s and 40s, the country was struggling to recover from the Great Depression, and President Truman stepped up with the New Deal policies. But farm and domestic workers, which more than half of the nation's Black workforce were in those two industries at the time, they were excluded from New Deal policies. That meant no Social Security, no fair labor standards, including minimum wage or an 8-hour workday, and state control of federal dollars allowed discrimination to continue unchecked. In 1945, President Truman proposed a universal national health insurance program. And notably, the American Medical Association, which at that time excluded Black doctors from being members, opposed this universal national health insurance program, calling it socialism and scaring people into thinking that it would disrupt their relationships with their providers and cause them to basically have poorer health care. And I would recommend for folks who are interested in learning a little bit more about that to check out the New York Times article entitled, "Why Doesn't the United States Have Universal Health Care? The answer has everything to do with race." It does a great job of laying out things like the Hill-Burton Act and how it provided federal grants for hospital construction to communities in need. And it particularly gave funding priority to rural areas, many of them being in the South. But it also ensured that states control the disbursement of funds and could segregate the facilities that were built with that funding. And so with the opposition to the National Health Insurance Program, things sort of continued unchecked in terms of people not having access to health insurance. And private health insurance plans became really popular, particularly with labor unions who were able to collectively bargain and ensure benefits for their members. But notably, many Black people were barred from even joining these labor unions. And so there was another, example of how systems were set up and policies were implemented that oppressed Black people and kept them from being able to access this valuable resources. So when you predicate access to medical care on a system of employer-based insurance, and you know that employer-based insurance is tied to those jobs that bar Black people, then it can't come as a surprise that there are lower rates of insurance for people of color, for Black people. So creating a system that ties health coverage to employment and then denying those types of employment to Black people has allowed racial health disparities to persist. So by the almost 1950 and 1948, President Truman won re-election and revived the call for health insurance, for a national health insurance program. Again, the American Medical Association opposed it, but this time the National Medical Association stepped up to counter that message. And the National Medical Association was comprised of Black doctors and medical students, which again, they were not allowed to join the AMA, so they created the NMA. The NMA stepped up and were pushing for a federal healthcare system for all citizens. They noted the segregated facilities, the unequal resources that were provided, the fact that Black doctors and nurses were not allowed to train or to practice on certain white facilities. And so this unequal two-tier system was very well known to them. And so they were pushing for a federal healthcare system to create more equity in our healthcare delivery system. And they were successful in their counter message campaign. And that led to the creation of our Medicare and Medicaid programs. Now, these programs were great on paper, but they didn't actually make progress towards achieving equity because facilities could choose not to participate. But in 1964, the Civil Rights Act outlawed segregation for any entity receiving federal funds. And so that was crucial because the Medicare and Medicaid programs were federal funds. And if hospitals participated, they had to agree to desegregate. And so that was instrumental in bringing about access to healthcare for a lot of people of color. It wasn't a silver bullet because not everyone qualifies for Medicare and Medicaid, but it was significant advancement towards expanding access. So next slide, please. There are longstanding barriers playing out today that are a result of this haphazard healthcare system that we've allowed to continue. We know that there was lots of misinformation, particularly when the pandemic first started. There were rumors that Black people were immune and they weren't going to, be impacted by this disease, which was absolutely not true. We have seen initial indications that doctors are less likely to refer African Americans for testing and for other interventions because of these really misguided beliefs about Black people not feeling pain or that they're impacted in some different physiological way than white people in response to different diseases. In fact, I've seen at least one study that reports physicians believe Black people have a higher pain tolerance and that there are physical differences between Blacks and whites that are just not true. We've also noted that there is a mistrust of our healthcare system because of medical assaults that have been noted in the past that have been inflicted upon Black people. And I've just listed, an example here, the Tuskegee syphilis research, and that has added to Black Americans' mistrust of the healthcare system. And there are ongoing examples of that, which is why we are concerned about the distribution of a vaccine if it were developed for COVID-19 and whether people would actually be vaccinated. Inadequate access to resources to meet basic needs. This was noted from the very beginning in terms of the impact of the smallpox epidemic on Black people who were not able to access safe living conditions or a living wage or nutrition, et cetera. So all of these basic needs that go unmet continue to be a barrier for people of color. Also, in our overrepresentation in the so-called essential workforce, this is another reason that we see these disparities, specifically with the COVID-19 pandemic, because more Black people are in those types of jobs that require them to still show up and interact with the public, and they're not able to telecommute as some people can and are able to isolate themselves and avoid exposure to the virus. And also in unemployment, this remains a barrier for people of color in that just in recently during this pandemic, as many as I can't recall the last counts, but at some point about 22 million people in the US had lost their jobs, and roughly the number of positions that had been created in the past decade in terms of job growth. And so there are new numbers coming out periodically about the unemployment rate, but what's not often mentioned is that the unemployment rate among Black people is always higher than white people. And you can, speculate as to the reasons for that, but the fact remains that because health insurance is often tied to employment, when you have higher unemployment rates, you have a disparate impact on Black people as a result, if they even were able to get employer-sponsored insurance with that job. And so it's also estimated that as many as 12 million people in the US have lost their employer-sponsored insurance as a result of the economic downturn. Next slide. So to address health disparities and advance health equity, we want to drill down on the lack of access to healthcare. Black Americans are 1.5 times more likely to be uninsured than white Americans, and less than half of private sector employers offer health insurance to employees. So this is significant. Also, it's significant that healthcare costs are unaffordable. So if you don't have health insurance, then you really are unable to access healthcare and specifically preventative services that are so important to address issues early on before they get out of hand. And so just tracking uninsured rates as it relates to race and ethnicity will show you this disparity in terms of access to healthcare. Next slide. So on one of the prior slides, it noted that our healthcare system kind of continued without any sort of significant developments until 2010, when President Obama was able to champion the Patient Protection and Affordable Care Act. And the ACA has really been a significant advancement towards health equity for our country, and specifically for people of color. And so this just kind of outlines some of the major provisions of the ACA that have gained popularity over the years. And we have to note that the sort of labeling of the Affordable Care Act as Obamacare is a function of racism. The parties that was opposed to the Affordable Care Act really wanted to tap into this anti-Obama sentiment that many people held for maybe because they were not in agreement with policies, but more so because of race. And so we know that that had to be a factor, because many legislators or Congress people, when they were going to vote on the Affordable Care Act, noted racial epithets were being hurled at them as they were walking through the crowd to make this historic vote. So race was definitely infused into the Affordable Care Act from the very beginning. But that really overshadows the more important points, which is that the provisions of the ACA have really benefited a lot of people. And if it were struck down, many people would lose coverage and lose access to the health insurance that they need in order to be healthy and to control those healthcare costs. And so we have been pushing to protect the Affordable Care Act as a tool to advance health equity. And specifically, the provision for Medicaid expansion would be lost if the Affordable Care Act was struck down. Next slide. So I'll just note that since this map was done, 2 more states have voted to expand Medicaid. They're Oklahoma and Missouri. But you'll note that a majority of the 12 remaining states that have not expanded are in the South. And that's significant because the South is home to 58% of this country's entire Black population. And so this map indicates in the darker blue shaded states the higher percentage of Black people living in those states. And so the refusal to expand Medicaid has direct racial implications for our state and others that refuse to expand. Next slide. So of course, Tennessee is one of those 12 states that haven't expanded. And the Tennessee Justice Center, in a coalition with several other organizations, has been leading the advocacy efforts for years to bring Medicaid expansion to our state. We've been really highlighting what we lose by not expanding and what we would gain if we did expand. And so part of, my sort of call to action is to start really highlighting the impact for people of color, especially at a time when racial tensions are more prominent in our discussions. We really need to start connecting healthcare justice to racial justice in these conversations. There's a large body of research that demonstrates that Medicaid expansion has improved access to care, utilization of services, affordability of care, financial security, and other benefits for low-income people who are disproportionately people of color. And some recent analysis show that expansion is associated with decreased mortality overall, and for certain specific conditions, and reductions in rates of food insecurity, poverty, home evictions, and improvements in measures of self-reported health and healthy behaviors. All of these benefits would flow to our state's minority population and would help reduce health disparities, which is crucial to address the ongoing pandemic and to prepare for the next public health crisis. Next slide. So I invite you to visit this webpage for more information. Also there you'll find a link to the Rooted in Racism paper that we published a couple of months ago that really goes into more detail about the role of racism in our health disparities and in the historical context for how we ended up in this situation. So thank you so much. You can go ahead and advance to the last one. Thanks for having me, and I'd be glad to take any questions.
Thank you so much for that amazing presentation, Kinika. That really laid out, so many different things. So everyone, please put your questions for Kinika in the chat. Several comments saying what an excellent presentation, and thank you for that.
Thank you. There's so much to this. I was trying to be mindful of time, so I'm sorry if I went over.
So one thing that you laid out in part of your talk is some of the criticisms, and particularly, the socialism criticism of any form of health coverage expansion and things like that. I was wondering how you personally address those criticisms, and particularly, with aspects of how to reframe that conversation on the health equity piece of what expansion would mean.
Yeah, I think I may have included this in the paper, but this idea of socialism is really interesting to me because our country is okay with socialism in certain aspects. Specifically in our healthcare system, people would be surprised to learn that our healthcare system is already largely socialized, but it's socialized in the context of tax subsidies that are provided to employers for providing health insurance. There's billions of dollars in tax revenue that are foregone because of the system that has been set up with employer-sponsored insurance, but nobody's attacking that. Nobody's attacking the efficiency of those programs that really incentivize overspending and increased prices rather than the efficiency of Medicaid. For all of its faults, it is a lower cost solution for providing health coverage to people, but it's constantly under attack. And I think it's because of the people and the perceptions of the people who benefit from that program. And so I would just say, when you talk about socialism, you really need to understand that we've already embraced socialism. We're just embracing it to the benefit of more wealthy people than lower income people.
Thanks for that answer, Kinika. Tony Gar asks, some states have looked at their budget through the lens of racism. Has Tennessee done this?
I've heard of that in other states, but I'm not aware of Tennessee undertaking any efforts like that. No. And I would be surprised if they did, especially considering the current makeup of our legislature and their resistance to even considering Medicaid expansion, even though the benefits are really quite clear without even considering racial implications.
There's a question, what would this approach mean? I think it's, sort of referring to that idea of looking at these things like the budget through the lens of racism. I think you could expand that to, thinking about what would it mean for a legislator to actually consider racism in making health policy.
Yeah, it would mean that you would do an impact analysis of each policy that you are considering to see how would this benefit people of color in particular, or on the flip side, how would this harm people of color? If there's a disproportionate impact in one way or another, that's something that would be considered as you're making laws and implementing policies. And so with the Medicaid expansion example, if the legislature were to undertake that analysis, they would look at, our health disparities. They would look at how Medicaid expansion has addressed health disparities in other states and consider, if we were to move forward with this, there's only upside here. We can really start to address the fact that Tennessee, is ranked 44th in maternal health, and that has a disparate impact on Black women because of those higher rates of maternal mortality. They can look at, the fact that Tennessee is really at the bottom in terms of life expectancies or access to healthcare, et cetera. So considering all those things and how people of color are disproportionately impacted, that would be the analysis that would be a part of considering, is this a policy we should pursue or not?
And in the interest of time, we'll make this our last question. Alan Hall asks, can you address how the Hill-Burton benefited or impacted the for-profit healthcare industry?
Yeah, I mean, Hill-Burton was a significant piece of funding legislation that that really is the genesis of our modern healthcare system in terms of facilities that were able to be built using those federal funds. And those, private facilities, to this day exist and, are kind of the backbone of our healthcare industry. And they largely received free tax money to start hospitals and hospital systems and profit from those that investment of federal dollars, and they were able to profit without really being held accountable to serve the communities and to serve them equally. And so, yeah, the Hill-Burton Act is kind of credited as like the infrastructure of our modern healthcare hospital system.
Thank you again, Kinika. That was a wonderful presentation, and we really appreciate you being here with us today.
Thanks for having me.
Yeah, thank you.